hydrostatic and oncotic pressure. So this is something that we are going to fully need to wrap both arms around, because this will play into so many other areas of the body for us to understand fluid dynamics. Okay, so this is something that you may have to listen to this piece a couple of times, but go back, listen to this multiple times so that you can grasp hydrostatic and oncotic pressures. So what we look at with these two things is it's how we maintain fluid balance between the interstitial space and the pulmonary capillaries. That's just one area where this plays. It plays all over the entire body, but it's the fluid balance between the interstitial space and the pulmonary capillaries. It's maintained through hydrostatic and oncotic pressures. Starling's equation puts into a number of pressures to help us understand this, but we're not going to dive into that. Just know that Starling's equation is associated with hydrostatic and oncotic pressures. So when we look at the hydrostatic pressure itself, and the hydrostatic and the oncotic pressures are the only pressures that can be measured out of the Starling equation. So those are a couple of things that we're going to look at here in just a second. So when we look at these two pressures, these two forces, one is trying to push the fluid out. The hydrostatic is trying to push the fluid out of the pulmonary capillaries and into the interstitial space. The normal value for hydrostatic pressure is 10 to 15 millimeters of mercury. When the hydrostatic pressure gets greater than the oncotic pressure, which is greater than 25 to 30 millimeters of mercury, fluid from the pulmonary capillaries spill out into the interstitial space and into the alveoli. This is the most common cause of pulmonary edema. This is the most common cause of pulmonary edema. So when we look at oncotic pressure, this comes from osmotic pressure. Oncotic and osmotic pressure are synonymous. They're the same thing. When we look at oncotic pressure, what this is doing, it is trying to keep fluid in the capillaries. It's trying to keep fluid in the capillaries, not into. It's trying to keep fluid into the capillaries or in the capillaries, or keep everything the way it's supposed to. Your normal pressure for oncotic pressure is 25 to 30 millimeters of mercury. And what's crazy is this is produced by the albumin and the globulin in the blood. So your albumin and your globulin in the blood are what help produce that normal pressure of 25 to 30 millimeters of mercury. So the next piece that we need to dive into is cardiogenic versus non-cardiogenic. So is it the heart that is causing the pulmonary edema, or is it some other factor that's doing that? And one of the factors that are non-cardiogenic, what we're going to do is we're going to spend a lot of time on that in a separate section. But cardiogenic versus non-cardiogenic, here we go. So causes of cardiogenic pulmonary edema, this could be a number of things, right? Arrhythmias, specifically PVCs, or premature ventricular contractions. Bradycardia that leads to low cardiac output. We could have systemic hypertension. We could have congenital heart defects, which is what we see with babies who are born with heart defects. We can have excessive fluid administration, meaning on us. We can have left ventricular failure, which we just finished talking about. Mitral or aortic valve disease, MI, cardiac tamponade, PE, renal failure, myocarditis, which is the inflammation of the myocardium. Remember the three different layers of the muscle in the heart. And then cardiomyopathies. These are diseases of the heart muscle impacting the structure or the function. Specifically with these cardiomyopathies, what we're looking at are viral infections. So non-cardiogenic pulmonary edema, we're going to spend a little bit more time on this one just because we talked about, what leads to that heart failure and how we see it. Now we're going to spend a little bit more time here in the non-cardiogenic. So when we look at it, we have 5 big kind of causes of non-cardiogenic pulmonary edema. So the first one that we're going to look at is an increased capillary permeability. So what this means is permeability means it allows things to pass. I like to think of it as a security guard at an event that just allows anybody in and out. So that would be like a loose permeability, but selective permeability means the security guard only allows certain things across. So when we have an increase in permeability, what we're doing is we're allowing more fluids or elements to move in and out without regulation. So these stem from some sort of infection or inflammatory or other processes. And typical causes, you can see this with alveolar hypoxemia secondary to high altitude. We can see this with ARDS. We're going to spend a lot of time in ARDS. Inhalation of toxic agents, chlorine, sulfur dioxide, nitrogen dioxide, ammonia, other hazardous materials that you breathe in. Pulmonary infections like certain pneumonias. You can have therapeutic radiation. You can have head injuries, acute head injuries that lead to cephalogenic pulmonary edema. You can have lymphatic insufficiency. So basically the garbage system is not showing up today. If the garbage system doesn't show up today, it's not removing all of that excess fluid. So anything that would decrease the lymphatic drainage would cause this lymphatic insufficiency. So other causes may be a tumor that obstructs the outflow. You could have damaged vessels. You can have an increase in systemic venous pressure, which will slow lymphatic drainage. Remember, this drainage drains into the right brachial vein and then goes into systemic circulation. So if I have an increase in systemic venous pressure, that will decrease the amount of drainage that is able to escape. And sometimes we see this with our post-lung transplant patients as well. So those are the patients that you would want to kind of be mindful of when it comes to lymphatic insufficiency. A decrease in the intrapleural pressure, this is a reduction in your pleural pressure. So every time we take a breath in, we reduce our intrapleural pressure. Remember, we breathe by negative pressure. So a severe airway obstruction, the patient needs to breathe harder and needs to create a more negative pressure in order for them to breathe. This negative pressure can create a suction effect on the pulmonary capillaries and actually pull fluid out of the pulmonary capillaries into the alveoli. The negative pleural pressure also promotes blood flow to the right side of the heart, but it obstructs or it hinders blood flow on the left. So if I'm hindering blood flow on the left, it's going to back up into the left atrium, the pulmonary veins, into the lungs, and we're going to end up with a situation similar to cardiogenic pulmonary edema. So when you get those negative pressures and the hindering of blood flow on the left side, blood will then pool in the lungs, causing an increase in the hydrostatic pressure. We know that the hydrostatic pressure encourages, when the hydrostatic pressure increases that above the oncotic pressure, it will encourage blood to move out of the pulmonary capillaries and into the interstitial space. So a lot of times we see this when you have a patient that has a pleural effusion and that pleural effusion is drained, especially when we drain it really quickly, we can end up with what's called decompression pulmonary edema secondary to the removal of a pleural effusion or a drainage of the pleural effusion, if you will. High altitude pulmonary edema, this is typically with altitudes of 8 to 10,000. We see this when people are trying to exercise or ski or hike in high altitudes that they're not acclimated to. So if you go on vacation and in Hawaii and you want to go hike Diamond Head and you haven't trained for it and you're not used to those altitudes, you could end up with some flash pulmonary edema, or what we call high altitude pulmonary edema, or another name for that is HAPE, H-A-P-E, which is just the abbreviation for high altitude pulmonary edema. Then the last one, this one doesn't happen very often, but a decrease in the oncotic pressure. When the oncotic pressure, what was the normal value again? 25 to 30 millimeters of mercury, gets below the hydrostatic pressure. What's normal hydrostatic? 10 to 15 millimeters of mercury. So when the oncotic pressure reduces below the hydrostatic pressure, that will cause an increase in the permeability of the fluids out of the pulmonary capillaries into the interstitial space. So what would cause something like this? So a couple examples would be overtransfusion or a rapid transfusion of hypotonic or normal tonic IV fluids, patients that are uremic, or patients that have hypoproteinemia or malnourished patients. And there's a couple of other ones, but those are the big three that I want you guys to kind of be aware of. The rapid transfusion of hypotonic or normal tonic IV fluids, uremia, or hypoproteinemia, which is a decrease in the protein in your blood, which is a form of malnutrition. Other causes, here's a list: allergic reactions, excessive sodium consumption, drug overdoses. For drug overdoses, we're looking at heroin, we're looking at aspirin, we're looking at amphetamines. This could be cocaine, anti-tuberculosis agents. This could be chemotherapy agents for cancer patients. So those could all lead to non-cardiogenic pulmonary edema. Metal poisoning, chronic alcohol ingestion, I think we talked about that a little bit earlier. Central nervous system stimulation, encephalitis, a PE or pulmonary embolism, eclampsia, or transfusion-related acute lung injury or TRALI. Those are all additional causes of non-cardiogenic pulmonary edema. So your clinical presentation, what does this mean? What is my patient going to show up looking like? So they're going to have trouble with activity. They're not going to be able to walk down the driveway to get their mail like they normally do. They're not going to be able to climb the stairs. They're not going to be able to stand for prolonged periods of time to cook. You're going to see an increase in weight gain, some anxiety, perhaps some delirium, dyspnea, shortness of breath. Specifically, you'll have some orthopnea. Orthopnea, remember, we have positional, or a patient that's in a recumbent position that has shortness of breath. Paroxysmal nocturnal dyspnea. This is whenever a patient's starting to fall asleep or has been asleep for a couple of hours. They wake up short of breath. A cough, fatigue. They can have cardiac arrhythmias. They'll have adventitious breath sounds. Most likely these could be like a cardiac wheeze. Or you could hear fine crackles. You'll have poor peripheral circulation, hypoperfusion. Your hypoperfusion will impact the brain, so you'll have some brain fog. You'll have cognition impairments. Your poor peripheral circulation can lead to cool skin, diaphoresis. You'll have cyanosis, or even some changes in their skin color, maybe some mottling, things of that nature. So other symptoms, we've already kind of hit some of these. There's some redundancy, but exertion, dyspnea on exertion. So I'm short of breath whenever I walk down the driveway to go get my mail. Orthopnea, positional, especially in a recumbent position. Shortness of breath. Fatigue is another big one. We have skeletal muscle weakness. We have a lower left ventricular ejection fraction. You would have a lower systolic blood pressure and a less robust smoking history. So these patients don't necessarily have to have a smoking history to have this level of shortness of breath. So just some additional information there.